Welcome to Raaonline. Today we are going to discuss about fascial spaces of hand. So competency for today's topic will be explain the infections of fascial spaces of palm. So already we have discussed about the various anatomy of hand, like what are all the layers in the hand. And we all know we have the deep fascia, that is palmar aponeurosis in the hand. So because of this various fascia and the fascial septa, there are fascial spaces going to be formed in the hand. So these spaces are known as fascial spaces of the hand. So these spaces are potential space. Like potential means normally these spaces will be a slit like gap, will contain only some loose areolar connective tissue. So that is the potential space. If there is a infection in the surrounding structure, the pus will be collected in this space. So in that condition, this space, these potential spaces will become a surgically significant spaces. So to discuss about this, knowledge of boundaries are important to limit the spread of infection. So if we know the boundaries, various boundaries of fascial spaces, we can do the surgical procedure and we can understand the extent of spread of infection. That is the importance of the fascial spaces of the hand. So going through the anatomy, so first we have the skin. The first layer we see is the skin. Once we reflect the skin, we see the superficial fascia. Once we open the superficial fascia, the next layer will be deep fascia, and that is the palmar aponeurosis in hand. So once we remove this palmar aponeurosis, we will be reaching the neurovascular structures of the hand along with the muscles. So we have the small muscles, the intrinsic muscles along with the long flexor tendons of the hand. Okay, so deep to this we have the metacarpal bones, and in between we have the interosseous muscle. So we will see the layer one by one. So once we remove the skin and superficial fascia, we reach the deep fascia. So here we can see the triangular palmar aponeurosis, which is a deep fascia of palm. Once we remove this deep fascia, see here we can see the reflected end of the palmar aponeurosis. So once we reflect this palmar aponeurosis, the deep fascia, we see the neurovascular bundles. See here we can see the superficial palmar arch, and the yellow color structure are the digital nerves. So along with this neurovascular bundle, below which we see the long flexor tendons. So we already have discussed about these long flexor tendons and ulnar bursa, radial bursa. So here the long flexor tendons for medial four fingers will be covered by a common synovial sheath, and that is known as ulnar bursa. And this, the tendon, long flexor tendon to the pollicis fingers, the thumb finger, that is the synovial sheath covering this flexor pollicis longus will be known as radial bursa. So here we can see the ulnar bursa, radial bursa and long flexor tendons, and with the lumbrical muscle. See here we can see a slender worm like muscle. So these are lumbrical muscle. So this will be below the neurovascular bundle. So once we reflect the long flexor tendons, we can reach the deepmost layer, that is the metacarpals. So here we can see the metacarpals, and in between the metacarpals we see the interosseous muscle. So here we can see both palmar interosseous as well as dorsal interosseous muscle, and we see a transversely running fibers, that is adductor pollicis muscle. Okay, so this is about the anatomy, overview of the anatomy of hand. So first we see skin and superficial fascia. Once we open, we see the deep fascia. Once we cut out the deep fascia, we reach the neurovascular bundle, that is superficial palmar arch and digital nerves. And deep to this we have the long flexor tendons, and deeper most layer will be the metacarpals and interosseous muscle. So here this section is cross section. See, we have seen the anterior view of the hand. So here we are going to see about the cross section. So in the cross section, you have to get oriented to the structures. So this is the cross section of the right hand. So this is the lateral aspect and this is the medial aspect. So in the lateral aspect, we all know near the thumb we have a group of muscle, and that is thenar group of muscle. And here below the little finger we have the hypothenar group of muscles. So here you just orient that this is the thenar group of muscles and this is the hypothenar group of muscles. Okay. So by looking these two, we can identify this is lateral aspect and this is medial aspect. Now coming through the layers from superficial to deep, the first layer we saw, that is the skin and superficial fascia, and below that this is the deep fascia of palm, that is palmar aponeurosis. So once we cut the palmar aponeurosis, next we see the long flexor tendons. So here we can able to see the cut end of the tendons, and deeper to this will be the metacarpal bones, and in between the metacarpal we see the interosseous muscle. Okay. Now you just have a look on this gross section of the hand. What are the various structure here? Now our facial spaces lying between this deep fascia, below the deep fascia and below these tendons. Right, we will see the next anatomy about these facial spaces. You just have to have this orientation of cross section of the hand. I told there will be facial compartments and fascia. So we all know the first deep fascia, that is palmar aponeurosis. Here in the palm there is a other fascia which covers the metacarpals and the interosseous muscle. See here, this is the palmar aponeurosis, and here you see the another fascia which covers the metacarpals and the interosseous muscle. So these two layers of deep fascia are connected by the palmar septa. See, you can just revise palmar aponeurosis. While we discussing the palmar aponeurosis, we discussed what happens to this palmar aponeurosis on the lateral aspect and on the medial aspect. So on the lateral aspect, this palmar aponeurosis become thinner to cover the thenar group of muscles, and that is known as thenar fascia. So from the lateral edge of the palmar aponeurosis, I told there will be a fibrous septa extending to the first metacarpal bone, that is this septum, and this septum is known as lateral palmar septum or thenar septum. Likewise, from the medial edge of the palmar aponeurosis, another septum extend vertically and it will be attached to the fifth metacarpal bone, and this septum is known as the hypothenar septum or medial palmar septum. Okay. So now we have three compartments, like one is the hypothenar compartment, then between the palmar septa, that is between the lateral palmar septa and medial palmar septa, we have intermediate compartment, and lateral most end we have the thenar compartment. And we have one more compartment known as adductor compartment. It is nothing but I showed a muscle in a deeper plane, that is adductor pollicis. So this adductor compartment is between this adductor pollicis muscle and the first dorsal interossei. So this is the adductor compartment. So we are going to divide the hand into compartments. So you can remember thenar compartment which contains the thenar group of muscle, hypothenar compartment which contains the hypothenar group of muscle, and the intermediate compartment which is going to contain all the flexor tendons, and the adductor compartment between adductor pollicis and the first dorsal interossei muscle. So this is about the various compartment of the palm. Now coming to the intermediate compartment. By now you all know what is intermediate compartment. So intermediate compartment is between the hypothenar septum and the thenar septum. So between these two septum, this compartment is known as intermediate compartment. Okay. So this intermediate compartment, we know it contains the long flexor tendons and the neurovascular structures. Okay, here this intermediate compartment is further going to be divided into two space. See here, you can see a obliquely running septa. So this is a third septa. Like already you know, lateral palmar septum or thenar septum and the medial hypothenar septum. So, these two septum already we know. Now, we have another septum which extending from the deep fascia from the palmar aponeurosis, under surface of the palmar aponeurosis to the third metacarpal. So, this septum is known as mid-palmar septum, or this is otherwise known as oblique septum. So, this is mid-palmar septum or oblique, because it is running obliquely. So, this is known as oblique septum. So, this septum going to divide the intermediate compartment into the lateral part, that is thenar space, and the medial part is known as mid-palmar space. You just remember, the intermediate compartment is divided into two space, thenar space on the lateral aspect and mid-palmar space on the medial aspect. So, by now you have to understand what is a compartment and what is a space. So, compartment, you know, this is thenar compartment, hypothenar compartment, and this is intermediate compartment. Now, this intermediate compartment has two space, that is thenar space on the lateral aspect and this mid-palmar space on the medial aspect. So, we have one thenar space and one thenar compartment. Thenar compartment will have the thenar group of muscle. The thenar space is a potential space. Okay. You have to understand that the difference between thenar space and thenar compartment. Now, these are all the various spaces of the hand, fascial spaces of the hand. So, we can classify that into palmar spaces, dorsal spaces and the forearm space of Parona. So, in the palmar aspect, we have, you already seen this mid-palmar space. So, palmar spaces are classified into mid-palmar space, thenar space, web space and pulp space. These four are palmar spaces. So, on the dorsal aspect, we have two space. That one is, the superficial one is known as dorsal subcutaneous space, and somewhat deeper is the dorsal subaponeurotic space. So, these two spaces are present in the dorsum of hand. And we have the another space, that is known as space of Parona, which will be there in the lower part of forearm, front of forearm. Okay. So, this is the classification of fascial spaces of hand, palmar spaces, dorsal spaces, the space of Parona. So, palmar space is further divided into mid-palmar space, thenar space, web space, pulse space. The dorsal space is divided into dorsal subcutaneous and dorsal subaponeurotic space. So, here again, this is to understand the thenar space and hypothenar space. So, thenar space, which is in the lateral part, and hypothenar, the mid-palmar space is in the medial aspect. Okay. So, now we will look at the various boundaries of these spaces one by one. Okay. First, we are going to discuss about mid-palmar space. So, mid-palmar space, as you have seen, it is a triangular space located under the medial half of hollow of the palm. Like here, you can see this is the mid-palmar space and this is the thenar space. So, this mid-palmar space is going to have the following boundaries. It will have anterior boundary, posterior boundary, this is lateral, medial boundary. So, these four boundaries will be there, this for mid-palmar space, and we also have to understand what going to happen proximally and distally, and which is going to act as an inlet of infection and outlet of infection. Okay. So, these are all the things we are going to discuss in mid-palmar space. So, the anterior boundary will be, see, you can see the palmar aponeurosis. So, this will be the medial part of palmar aponeurosis, and below the palmar aponeurosis we can see the ulnar bursa covering the tendons of medial 3 fingers. Okay. So, this will be the pollicis thumb and this will be the index finger, and these three for middle, ring and little finger. So, this ulnar bursa covering the medial 3 fingers, tendons of medial 3 fingers. So, this is going to form the anterior boundary, and along with the neurovascular structure, the digital vessels and nerves which is supplying the medial 3 fingers. So, all these structures going to form the anterior boundary. Remember the medial part of palmar aponeurosis, then the neurovascular structure that is known as superficial palmar arch and digital nerve. And you can see the ulnar bursa, and it is nothing but the synovial sheath enclosing the flexor tendons. And along with this flexor tendons, we also have the lumbricals muscle for the medial 3 fingers. So, these are all the anterior boundary. See here posteriorly we can see a fascia which is covering the medial 3 metacarpals. See, we can see here the cut end of metacarpal. So, this is first, second, third, fourth and fifth metacarpal. So, the posterior boundary will be the fascia covering the medial 3 metacarpals. And between the metacarpals we have interossei. So, that fascia going to cover this metacarpals and interossei muscle. So, this is about anterior boundary and the posterior boundary of mid-palmar space. Now, laterally, see, we can see this septum. We already discussed this septum. This is the oblique septum or mid-palmar septum. So, this septum will be on the lateral aspect of mid-palmar space. So, this oblique septum or mid-palmar septum going to separate this mid-palmar space from thenar space. So, this is lateral boundary formed by intermediate septum or mid-palmar oblique septum. And medially we have medial palmar septum or otherwise known as hypothenar septum. So, this septum going to separate this mid-palmar space from the hypothenar compartment. Okay. So, this is about anterior boundary, posterior boundary, lateral and medial boundaries of mid-palmar space. Then proximally, that is towards the forearm, this proximally it is going to continue with the forearm space of Parona. Remember, this mid-palmar space will continue with the forearm space of Parona. And distally, that is towards the digits. Distally, it is going to continue into this web spaces. So, medial 3 web spaces will have this extension of this space, mid-palmar space. Okay. So, the inlet of infection, that means which is going to act as a inlet source of the infection. We already know anteriorly we have long flexor tendons, and covering that long flexor tendon we have ulnar bursa, right. So, if the infection any infection in that synovial sheath, ulnar bursa, that infection going to act as a source of infection. That is why the inlet of infection is by the ulnar bursa. So, this is ulnar bursa going to act as a inlet of infection or source of infection to the mid-palmar space. Outlet of infection, that means how we can let out the pus from the mid-palmar space, that is mean by outlet of infection. So, here we saw this distally it is going to end in the web space. So, through the lumbrical canals, lumbrical muscle tendon will be going to this web space. So, through this it will be continuous to the web space. If we open this web space, we can let out the pus from the mid-palmar space. So, that is the meaning of outlet of infection. So, outlet of infection will be the lumbrical canals and web spaces. Okay. So, this is about the mid-palmar space. So, in the mid-palmar space, we have to discuss the boundaries, anterior, posterior, medial, lateral, and what happens proximally, what happens distally, and which act as a source of infection, and how we can treat if there is a pus in the mid-palmar space. Next, we are moving on to thenar space. See, thenar space also a triangular space, but it is located under the lateral half of the hollow of palm. That means near the thenar group of muscle. So, again the thenars, we can discuss the thenar space under the following headings: boundaries, anterior, posterior boundaries, medial and lateral boundaries, then what happens proximally and distally, then which act as a source of infection, and how we can let out the pus. So, we are going to discuss under these following headings. See here we can see the green color slit, that is the thenar space. This yellow color space we have discussed, that is mid-palmar space. Now this green color space is the thenar space. Okay. So now thenar space will have anterior boundary, posterior boundary. This is medial and lateral boundary. Anteriorly, it will have the palmar aponeurosis, the lateral part of palmar aponeurosis. Then we have the tendon, long flexor tendon. Below the palmar aponeurosis, we will have the long flexor tendon to the index finger. Medial 3 fingers will form anterior boundary for mid-palmar space. The tendon of index finger will form boundary for anterior boundary for the thenar space. And we also will have the flexor pollicis longus tendon. So these two tendons will be there anteriorly along with first lumbrical muscle. And posteriorly, the fascia covering adductor pollicis muscle. The purple color structure is adductor pollicis muscle. So covering this muscle, we have the deep fascia. So this fascia is going to form the posterior boundary. Okay. So anterior and posterior boundaries of thenar space. Then medially this septum, and you know this is oblique septum, which is going to form the medial boundary, and it is going to separate the thenar space from the mid-palmar space. And laterally we will have the lateral palmar septum. So this lateral palmar septum will divide the thenar space from thenar compartment. And they extend proximally and distally. Proximally, this will not extend into the forearm. This will be the anterior and posterior walls of this space will be fused with the flexor retinaculum and carpal tunnel. Okay. So just remember, only mid-palmar space will continuous with the forearm space of Parona. This space will, the thenar space will not continue to the forearm. And distally, it will communicate with the web space, the first web space. Remember, the mid-palmar space will continuous with the web space of medial 3 fingers, and first web space is for thenar space. Inlet of infection. So if there is an infection in the synovial sheath of flexor pollicis longus tendon, that is radial bursa, or any infection of synovial sheath of index finger. So if there is an infection in these structures, it will act as an inlet of infection for thenar space. And we can let out the pus by incising the first web space, that is known as the outlet of infection. So here again, this is to revise what is ulnar bursa, radial bursa, and what is the relation with this space. So here we can see the long flexor tendon for the index finger, middle, ring and little finger. Okay, and these are covered by the synovial sheath, and that is known as ulnar bursa. So this ulnar bursa, remember this is ulnar bursa. This is going to be related to both the thenar space as well as mid-palmar space. Just remember, the ulnar bursa anteriorly related to both thenar space and the mid-palmar space. But the radial bursa, see, which is a synovial sheath covering the long flexor pollicis longus tendon, this is going to form or it is related only to the thenar space. But ulnar bursa is related to both the spaces. Okay, to show that relation here. What is the relation with the ulnar bursa and radial bursa? See, now here you can see this picture is a normal picture of the hand. So we can see the thenar space on the lateral aspect, and we can see mid-palmar space on the medial aspect. So this is the normal potential space. Here we can see some collection in the mid-palmar space. See here. So this is a collection of pus in the mid-palmar space. So collection of pus is known as abscess. So this is the abscess in the mid-palmar space. See here, this space, the thenar space is enlarged here. So here collection of pus in the thenar space, and that is known as abscess in the thenar space. So this is how these two potential spaces become clinically important. If there is a pus, we have to let this pus out. Okay. So this is the thenar abscess, this is mid-palmar abscess. and this is the normal thenar and mid-palmar space. So, how we are going to let out? We saw that outlet of infection, right? So, for mid-palmar abscess, the outlet of infection, outlet of this mid-palmar space will be the medial 3 web spaces. So, we can make a vertical incision in medial 3 fingers to let out the pus. Okay. So, now next we are moving on to the web spaces. We have seen mid-palmar space, thenar space, and third palmar space is web space. See, web spaces are nothing but these are subcutaneous spaces which is present in each interdigital cleft. So, we have 5 fingers, will have 4 interdigital cleft. So, in each interdigital cleft we have the web spaces. So, this web space extend between the free margin of the skin. So, in between the finger we have the free margin, right? So, from the free margin to the transverse metacarpal ligament. So, this will be the extent of web space. And what is there inside the web space? See, you can see artery and the nerve. So, there will be digital artery, digital nerve, and there will be a lumbrical tendon. Tendon of lumbrical also will pass through that web space. Okay. And apart from these 3 structures, there will be fibrofatty tissue. These are the contents of web space. See, web space become important because we are going to open the mid-palmar space and the thenar space through this web space only. That is why this web space becomes important. Okay. Here again you can see this is the digit thumb, you can see index, middle, ring and little finger. So, between this we see interdigital cleft, that is the web space. So, this web space will contain, see, you can see the loose connective tissue, fibrofatty tissue, and this yellow color structure is a nerve, digital nerve, and you can see the digital artery. See, and you can also see the lumbrical muscle. Lumbrical. So, this lumbrical muscle and the tendon will be the content of this web space. Okay. So, through this lumbrical canal only the spaces, mid-palmar and thenar spaces will be continuous with the web space. So, if we open this web space, we can open the pus, collection of pus in the mid-palmar space and the thenar space. Okay. That is the importance of web spaces. So, web spaces between the interdigit, and it will be a subcutaneous space and will contain fibrofatty tissue, digital nerve and vessels, lumbrical muscle. Here you can see the lumbrical muscle, here you can see the lumbrical muscle extending into the web space. Yes, the fourth space, fourth palmar space is pulp space. See, this is very important because in the hand the most exposed region will be the tips of the finger, these pulp space. So, frequently we get injured with the pin prick, right? So, that is why this space become important, pulp space. So, this pulp space also a subcutaneous space which is present on the palmar aspect of the tips of the finger. So, all the fingers will have the pulp space including thumb. What is the extent of this pulp space? See, this is proximal extent and this is distal extent. Distally we have just the tip of the finger. Okay, and distally it is closed. And proximally if we see, the green color structure will be flexor digitorum profundus tendon. Okay, and covering this flexor digitorum profundus tendon, we will have fibrous flexor sheath. Okay, so this fibrous flexor sheath will be attached to the distal phalanx, the periosteum of distal phalanx. Okay, and here we have the distal skin grease, digital grease. That grease also will be tightly adherent here. So, by these fusions, proximally also the pulp space will be a complete space. It will not continue with the proximal digits. Okay. You just have to remember that the pulp space is closed proximally as well as distally. So, proximally it is closed by this fibrous flexor sheath merging with the periosteum of distal phalanx as well as by the crease, the distal digital crease. So, this is about the boundaries. Now, seeing this pulp space, see, there are many lines you can see here. These lines represent the septa, fibrous septa. So, this pulse space is divided into numerous compartments by these fibrous septa, small compartments. So, this compartment is going to have the fibrofatty tissue. There will be only fat in this compartment. Okay, and the digital artery and nerve will be coming through this pulse space and will supply the phalanx and the fat structures. Now, what is the importance of this blood supply to the pulse space? See here, you can see a digital artery, and this digital artery going to enter into the pulse space and divide into branches to supply the distal phalanx. So, now the distal phalanx will have the base of the distal phalanx, shaft and head of the distal phalanx. Okay. See here, the base is not contained within the pulse space. Base is outside the pulse space. So, to supply this space, there is a branch, separate branch known as the epiphyseal branch. So, to supply this epiphysis, base of the distal phalanx, a separate branch arises from this digital artery before entering into this pulse space. Okay. So, the other branches, the diaphyseal branches will arise after entering into the pulse space and supplies the rest of the distal phalanx. Okay. And just remember, these arteries, all the branches are end arteries. The end arteries will not anastomose with the other artery. If the arteries are blocked, that area will undergo a avascular necrosis. So, that is why this end arteries, you have to remember, these digital arteries are end arteries. Okay. Now, if there is a collection inside this compartment of the pulse space, that is known as phelon or whitlow. Just remember what is phelon or whitlow. It is a abscess or collection of pus inside the pulse space. So, if we are not going to treat this abscess, these abscess will be going to compress on this digital branches. So, if it is going to occlude the branches, I told it will be an end artery. So, these vessels will be blocked. So, what happens automatically? The distal phalanx will not get the blood supply. So, that will go for avascular necrosis. Just remember. So, in the case of neglected or long-standing phelon or whitlow, the blood supply to the distal phalanx will be affected. So, this distal part will undergo avascular necrosis if it is untreated. But what happens to the base of the distal phalanx? It will escape from the avascular necrosis, because I told the epiphyseal branch, there will be a separate epiphyseal branch which will arise before entering into the fibrous septa pulse space, and that branch is going to supply the base. So, that artery will not be compressed in the case of pulse space infection. So, the base of the distal phalanx alone escape from avascular necrosis. The other part will undergo avascular necrosis if the pulse space infection is left untreated. Okay. This is a very important surgical point you have to remember, the avascular necrosis of the distal phalanx. Now, how you are going to treat this pulse space infection? See here, you can make a longitudinal incision on the side of the pulse space. So, if you make a longitudinal incision, you can open up all the septa. So, you can drain all the pus. So, that is the importance of longitudinal incision along the pulse space. Okay. See, if you make a transverse incision, that will not open all the compartments. Okay. It will only open one compartment. See, remember, if you are making like this, you will open only one compartment. Other compartment will be loaded with pus. Okay. So, you have to make a vertical incision where you can open all the compartments and you can let out the pus. Okay. You just remember these 2 points in pulse space. One is avascular necrosis. The other important thing will be the vertical incision or longitudinal incision to open all the compartments loaded with the pus. So that is about palmar space. Now coming to the dorsal spaces. So in the dorsal aspect, see, we can see the skin, and below the skin is the superficial fascia, and next to that we have the deep fascia along with the tendons, extensor tendons. Okay, and deep to this extensor tendon will be the metacarpals, and in between interossei muscle. So we have now two space on the dorsal aspect. One is dorsal subcutaneous space. That space is nothing but it is between the superficial fascia and this deep fascia. This space is known as dorsal subcutaneous space. And dorsal subaponeurotic space is deep to this deep fascia. It is between the fascia covering metacarpals and the deep fascia. That space is known as dorsal subaponeurotic space. Okay. So subcutaneous is between superficial fascia and deep fascia. Subaponeurotic is deep to this deep fascia. Okay, you just remember that. So in the case of subcutaneous space, dorsal subcutaneous space, if there is an injury over the knuckles, this space will be collected with the pus or fluid. Okay, so it will be a larger swelling. So we have to open this swelling, that is known as incision and drainage. So where the maximum bulging you are seeing, in that site we have to make a nick to open up the swelling and let out the pus. Okay, that is about the subcutaneous space, dorsal subcutaneous space. For the dorsal subaponeurotic space, I told it will be deeper to the deep fascia. So we have to make an incision on either side of the extensor tendon. Longitudinal incision on either side of extensor tendon. If you make a longitudinal incision, we can let out the pus collected in this subaponeurotic space. So here again you can see the abscess in the hand, various abscess. See here, this will be the thenar abscess, where we see swelling on the lateral aspect. See here, this will be the mid-palmar abscess, where we can see the swelling in the middle of the palm. And this is the dorsal subcutaneous space swelling. So this is dorsal subcutaneous abscess. Here again you can see pus in the adductor space. So now moving on to the next space, that is forearm space of Parona. So here you are seeing a cross section of the forearm. So in the forearm you all know there will be two bones. On the lateral aspect there will be radius bone, and on the medial aspect will be the ulna bone. Okay. So this is the posterior aspect, and in the anterior aspect we see many muscles. The green color structure are the tendons and muscles. Okay, here again you can see a red color structure. So that red color space is known as forearm space of Parona. So this is bounded anteriorly by some tendons and posteriorly by some muscle. Okay. So the posterior muscle which is bridging this radius and ulna in the lower part of forearm is the muscle. The muscle is known as pronator quadratus. Okay. If you recollect the muscles of front of forearm, it will be arranged in superficial group and deep group, and in the deep group the deepest muscle will be pronator quadratus. So it is a quadrangular muscle bridging radius and ulna. So this will be forming the posterior boundary for forearm space of Parona. Anteriorly it is bounded by the flexor digitorum profundus muscle. That muscle will be forming the anterior boundary for forearm space of Parona. And laterally and medially, the lateral border of forearm and the medial border of forearm will be the lateral and medial limit. You just have to remember it is between the muscles, or else you can say otherwise it is an intermuscular space. So between flexor digitorum profundus muscle and the pronator quadratus muscle we have this forearm space of Parona. See here you can see the deep group of muscle. In the deep group of forearm there are three muscles. You are seeing flexor digitorum superficialis, which is actually a muscle of superficial group. Deep to this will be profundus. And this is flexor pollicis longus to the thumb. and deeper to this will be the forearm space of Parona, and behind that will be the pronator quadratus muscle bridging the radius bone and this ulnar bone. Okay. Again, you can see infected forearm space of Parona. Here you can see the infected space. So I told it is a deep space or intermuscular space in the lower part or distal part of forearm between pronator quadratus muscle and flexor digitorum profundus tendon. Okay. And in the first space, remember mid-palmar space, I told mid-palmar space will continuous with this forearm space of Parona. So, forearm space of Parona will continuous with mid-palmar space. So, flexor tendon sheath infections. So, any infection in the flexor tendon sheath, the synovial sheath infection will lead to collection of pus in the forearm space of Parona. So, there will be a swelling and tenderness, and this digits also there will be painful flexion of these digits will be there. Okay. This is about the features of infected space of Parona. Now, we have seen all the spaces. If there is a collection of pus in these spaces, what we are going to do? We have to make an incision and we have to let out the pus. That is the treatment. So, there is some rule for making an incision. These two rules are basic rules, like you have to follow for any incision. So, if you are going to making an incision, the incision should be parallel to major skin grease. Like if you take palm, you have a skin grease, major skin greases, right? So, the incision should be parallel to the skin grease. It should not be right angle. It should not cross the skin grease at the right angle. Okay. So, if it is parallel, the healing will be faster and there will not be uglier scar. If it is a right angle to the major skin grease, what will happen? It will not properly close. The margin of the wounds will not be properly closed. There will be a tension. So, it will not heal properly and the scar also will look ugly. Okay. So, because of that, we have to follow these two basic rules before making any incision. Incision should be parallel to the skin grease and it should not cross the skin grease at the right angle. So, now for letting out the infection in these spaces, we are going to make an incision. So, if there is a abscess in the thenar space, we are going to making a incision in the first web space. A vertical incision in the first web space. If we make an incision, we can open up the thenar space. If we are going to make a vertical incision in the medial 2 web space, we can open up the mid-palmar space. And to the pulse space, I already told we have to make a longitudinal incision along the distal phalanx. Okay. So, that is to open up all the compartments which are filled with pus for the pulse space. And for forearm space of Parona, see, we can make a vertical incision on either side of the borders of the forearm. Okay. So, either we can make a vertical incision on the lateral border or medial border. So, all the incision here are vertical incision, you remember that. For thenar space, first web space. For mid-palmar space, medial 2 web spaces. For pulse space, we are going to make a vertical incision in the pulp space. And for forearm space, we are going to make a vertical incision along the borders of the forearm. So, now we have finished about the facial spaces, the boundaries, various boundaries, and what are the route of infection, how we can drain out the pus. So, we have 2 questions here. The first question is mid-palmar space continuous with space of Parona. Is this statement is true or false? See, mid-palmar space will continuous with the forearm space of Parona. This statement is true. Only the thenar space will not continue with the forearm space of Parona. You just remember that. So, if any infection in the mid-palmar space, it can spread to the forearm. That is the clinical importance of this statement. The second question is, base of the distal phalanx escape from avascular necrosis in a neglected pulse space infection. Whether this statement is true or false? Yes, this statement is true. The base of the distal phalanx will escape from avascular necrosis because base of distal phalanx is supplied by a separate epiphyseal branch which will be given off before entering into the septa, fibrous septa of the pulse space. So, base alone will escape from avascular necrosis. The rest of the distal phalanx will undergo avascular necrosis. Okay. So, that is about the importance of pulse space and the various spaces of the hand. Thank you.